Our next speaker, Dr. Abbas Al-Firdan, right? صح إن شاء الله. Is a consultant of orthodontic from Bahrain. I have visited Bahrain since 10 years ago, more than 10 years in Al Khalid Hotel, right? With Dr. Ghassan Dif. All right. Dr. Ghassan, Dr. Abbas is got BDS from Edinburgh, King Saud University, and master in University of Edinburgh, and FRS, and Royal College of Ortho of Edinburgh, and he is a membership of orthodontics and fellowship of dental faculty of Royal. Of course, today will inshallah be so much enjoyed with the speech of Dr. Abbas. Welcome, Dr. Abbas.
Good morning, Cairo. Actually, it is a difficult task for me to present after Dr. Adel. He's a very meticulous clinician and academician, but I'll try to do my best to impress you. My presentation will be in the same topic that Dr. Adel did, which is treating class 3s, the modern or the contemporary modalities to treat class 3s. But my presentation will be in a different way. I'll just walk quickly on different ages and different management of class 3s. So I hope you will enjoy this coming half an hour with me. I'll start with this slide. Dr. Edward Angle, the father of orthodontists, once said in 1907, which is almost 112 years ago, he said, if you want to give the worst task to an orthodontist, give him a class 3 to treat. So that tells you that class 3s are difficult to manage and difficult to treat at that time, the time of Edward Angle. And now we are, let's say, 112 years, and we want to know, are we still having this difficulty, or we made a big stride toward making treatment more predictable and more effective? As Dr. Adel said, in early ages of Angle, he said that class 3s are the mesial occlusion. These things are, we all know, we knew it from the BDS courses. This is the basic things, and it's still there. And it is a progressive problem that the growth of the mandible gets worse. I mean, the mandible gets worse with the growth, and the maxilla get held more with the growth as well. And we knew since long time that there is something called the natural dentoalveolar compensation, which is the proclination of the upper incisor and the retroclination of lower incisor. These information, we knew them old time. And also we knew that things like persisting mouth breathing, a certain habit, make things worse and make class 3 more apparent. And Dr. Adel also mentioned about the etiology of a class 3s, and he went into details about the Habsburg jaw. And as he elaborated really nicely how the genetic part of etiology in the causation of a class 3. And also Dr. Adel mentioned about what signs commonly seen in a class 3s. Narrow upper arch, cross bites, crowded upper arch, retroclined and crowded lower arch, and proclined upper incisors. These are all, we knew them long ago, but the modality of treatment, that the way we treat patients, it was complicated in the past and getting simpler and simpler with time. So I'm glad here today to share with you some of my humble experience in treating class 3s. I will run, not like Dr. Adil, go into details and run because I have 6 cases. So you will see me run, but stop me whenever, or at the end you can ask me anything about them. Yeah. So I'll discuss 3 cases treated with Carrera motion appliance, which is a distalizers. I have 1 case treated with Invisalign, a case treated with orthographic treatment, and another one, very simple. All the general dental practitioners do it in every day, treating simple cases, making a lot of effective outcomes using a removable appliance. So it's just like a mix of everything. So I'll start with, maybe some of you don't know what is Carrera Motion 3 or 2. I'll just go a little bit in details in this one because it might be new for some of our attendees. The Carrera Motion is basically, it is a metal rim that it's connect between the canines to the first molar. And it's composed of a hook on the canine bed and the base fixed based on the canine. And then we have a stiff arm made of stainless steel and a curved fashion that run across the premolars and that allows premolars to rotate and to align freely. And then finally, we have the molar pad, which is a ball and a socket, and it gives more freedom in the movement of 6s, and it allows movement of 6s without rotation and without tipping. The advantage of Carrera Motion appliance, it is simple design, user-friendly, reduce the need for extraction, reduce need for orthognathic surgery. I'm saying reduce, I'm not saying eliminate. And it shortened the treatment time. And basically, this is the setup. It's very simple setup. It's Carrera Motion on the lower arch between 3 to 6. Sometimes you put it between 4 to 7 or 4 to 6, according to the case, because sometimes you have the 3s rotated. So you go a little bit in the back. You put a tube on the 7, or if it's not available, the 7, or not enough erupted, you put it on the 6. And then there is a specific protocol for the elastic. And to hold the upper incisor not to procline and enhance the protraction of the maxilla, you put a thermoplastic retainer on the upper arch. Basically, this is it. It allows use of elastic early. We have clear motion Carrera, so those are concerned about aesthetic, still do it. For kids, you can use colored motion Carrera to make them more happy. There is a minimal interference with speech. Eliminate facial appliance, because some of our community in Bahrain, I don't know about here in Cairo, the modality that Dr. Adil discussed, which is the facial mask, they might not accept it socially. So that's a good alternative for those. And it is oral hygiene friendly. I'll just run quickly. This is the how it works. We put it on 3 and 6 on the lower arch. And then we have thermoplastic retainer in the upper arch. And basically, it's correcting the canine relationship to class 1. This is how it works. As I said, I'm not going into details, but I'm happy to answer whatever question coming to your mind. Dr. Adil elaborated a lot about the timing to treat class 3s, and I really second on his opinion that treating class 3 early is a good thing. I mean, going to treat below 10 is the way you have to. So you have to detect the class 3s early. So would I treat people in early ages? Yes. I might be a little bit adventurous because you will see me treat them in primary dentition. But on severe cases, I would. And if I find the patient cooperative, has notions of a need and they demand it, I would start early. So would I start early? I would. Why? I won't go into details about the literature because Dr. Adil really elaborate nicely, but a lot of studies showing that treating early is the best in the effectiveness to treat class 3s. Okay? Why early? Because it eliminates the functional discrepancy created by the crossbite and remove the hindrance on the maxilla and enhance the facial profile. And you cannot imagine how happy is the patient when you socially and psychologically when you relieve their malocclusion early in life. So I would invite you to join me in this journey. We will go from the younger age and we go up the ladder until we end with adult. So the first case, I'm doing it. I told you sometime I start a bit early. Maybe you will call me adventurous, but I had a few cases that I do on primary dentition. This young girl is in primary dentition. She's 5 years old with the mandible almost totally enclosed within the maxilla. And she had a mandibular and dental central line shift to the left. And the treatment was by doing a quad helix plus carrera motion. For her, the treatment will be ongoing because she will go into changing. And the challenge is how you will do a retentive plan to hold on with your result. This is the most important. How you hold on whatever you achieved in primary dentition into later in life. So when the patient grows and new teeth comes, your jaw is under control. And that's a challenge. And we, as an orthodontist, we have to accept the challenge in order to do good things for our patients. So the patient's clearly showing profile and the 3/4 how class 3s she is. Dentally, she's showing the maxilla almost totally enclosed within the mandible. And we can see the amount of class 3 relationship in the canine areas, in the anterior areas, and the molar areas. And there is a central line shift, very evident here. And my treatment is, as I said, quad helix and carrera motion 3 and an elastic protocol that we use specifically for young children. It is different than the protocol for adults, of course. And you will see that there is massive change in the correction. As soon as your patients are really cooperative, disciplined, you will see results. As soon as you are following the right protocol. And you can see the profile getting better all the time. And you will see also that the patient is now going into early mixed dentition. And here, I usually keep my carrera elastic only nighttime with light elastic, just to hold on with the correction. This is the class 3 corrected, and in matter of fact, it is over-corrected. And you will see how the profile is getting much better with the treatment. And psychosocially, you cannot imagine how improved they are and how effective and happy they are when you do things for them early in life. So I finished one. I'll go to the next. Most of our dentists will find class 3s in early mixed dentition as anterior crossbite. And that's the best time to catch them and to treat them. And sometimes we treat them only with a simple treatment. So this is my second case, a 9 years old, early mixed dentition, class 3s, and crossbite in the anterior area. And both upper and lower incisor are retroclined. And here I did a very simple, all days practice that every dentist do Even in the BDS course, we do some of them. And that really helps. It doesn't matter how simple it is. What matters is you relieve the malocclusion of the patient and let him continue with his dental and facial growth normally. So in this case, we can see that the treatment, I'll just elaborate more how I design my removable appliance. I do it very simple design. Adam cribs on the posterior teeth for retention, south end clasp on the upper incisors, and then anterior screw to push the 4 incisors forward, and a posterior bite plane to relieve the bite. And this patient, within 2 months, the case is corrected. Then you might decide to use the same appliance as a retainer for a few months, and then you leave the patient to grow normally, because you will need the patient, you will need the energy of the patient later on in life. So make your interception as simple and less demanding as possible, because you need really the energy and the discipline and the cooperation of the patient later on in life. So this is a patient on follow-ups. You can see naturally, spontaneously growing into proper, stable class 1 incisor relationship. He will develop other problem that he meant to develop it, and then you deal with it later on life. But basically, you interfere timely, quickly, simply, you finish, and you leave him alone. That's the way we have to manage those patients. So I finished 2 cases. I'm running, like I told you.
Yes.
And the committee here is happy about me because I'm running.
We have so many questions, but we are letting you up to the end.
Okay.
Every case has 2.
Okay. So we finish early mixed dentition. Now I'm giving you an example in early permanent dentition, or let's say late mixed dentition. And this is a good time to merge your 2 phases. If you have 2 phases of treatment, instead of waiting, you do phase 1 and then you go to the comprehensive phase 2. And this case, 11 years old boy, late mixed dentition, early permanent dentition, let's say, with an overjet of -2 millimeter, crowded upper arch, impacted canines, as well as retroclined lower incisors. So we have a problem of crowding to manage, the class 3 to manage, as well as maintaining the torque of the lower incisor while we are correcting our class 3. So few challenges in the road here. So my treatment was a 2-phase treatment, motion carrier 3, plus upper and lower self-ligating system. This is the boy at the start of the treatment, showing the class 3's malocclusion. And we have an impacted upper left canine, as well as class 3 malocclusion in all aspects. You can see the amount of crowding we have in the upper arch, and the upper left canine is impacted labially. Cephalometrically, he shows a skeletal class 3 of almost -0.5. Almost 0, and the width analysis is -5, so he's a class 3. And away from that, he has good other dimensions. After we finished Carrera motion 3, sorry, he went into class 1 canine and molar relationships, and then the comprehensive treatment is to align the upper arch, correct the angulation of the lower incisor, as well as maintaining class 3 correction. I'm retaining the canines by extending my bonded retainer till first premolar in order to make sure I'm retaining my impacted canines in place. This is his final occlusion. And this is his profile getting better after the treatment. Okay, what about older patient? Is still, I mean, if they pass their puberty growth spurt, would they also be amenable for treatment without surgery? I'll share with you this case with a patient. Sorry, I'm back. This is 18 years old. And all of us knows when a patient comes with us with a trauma, usually the upper incisor affected with the trauma. In class 3, you see, in his case here, both upper and lower incisors with the trauma, they got affected and knocked down. So that could be a change from class 2 div 1, where the trauma all taken by the upper incisor. In this case, the upper and lower incisors are affected by the trauma. So this patient had a history of trauma, upper left central incisors, root canal treated, and the lower incisor broken crown, but the pulp is not affected. He has a class 3, edge to edge, and we treated him with Carrera motion appliance again here, and as well as with fixed self-ligating system, and followed by prosthetic replacement of the traumatized teeth. I mean, not replacement, shaping of the traumatized teeth. This is his intraoral condition, as we said. Moderate crowding in the upper arch, crowding in the lower arch, and edge-to-edge bite, class 3's canine and molar relationship. You can see clearly the amount of class 3's he has, and the traumatized teeth is very clear here. The upper left central incisor as well as the lower incisor. It shows the root canal treatment that's done for the upper left central incisor. Cephalometrically, he showed minus 0.6 the degrees, as well as width analysis negative, which is a class 3 malocclusion. That's him after we finished the motion Carrera, normalized the canine class 1 and the molar class 1, and corrected the overjet. Now is the prosthetic face. We normalized the zenith of the upper left central incisor to match the right one, change the composite core on that tooth, as well as prepare the tooth for Emax restoration. The lower incisor was treated with composite restoration, a new composite restoration. That's the Emax in place and the new composite restoration. This is just to show you a glance of how the changes took place. His profile is getting better, maybe not his haircut, but that doesn't do with me, but his profile really get better than before treatment, as well as his smiles and orthodontic outcome as well. Would it be possible to treat all class 3s with 3 cases without surgery? Dr. Adel mentioned before that -4 A and B is the term. Sometimes you cannot do it without surgery. So my next case will be a surgical case. This is 21 years old patient in university, and he is severe psychosocial constraint by his facial and dental characteristics. And he was really crying for surgery. He came, he knows he wants surgery, and he demanded for surgery. So these cases are really surgical cases. His overjet is not 0, is -6, sorry. And he has well-developed and aligned upper and lower arches. He has a deviated mandible and central line to the left. Otherwise, he has well-developed upper arch, no crowding in the upper arch. It is unlike the normal, and it's well-developed lower arch as well. So the case is crying for surgery. You can see the amount of negative overjet here. He has 4 wisdom teeth, and surgeon usually would demand them removed a few months before surgery in order to heal nicely in the surgical cut.
It's in the past. Now it's cut done immediately.
Yeah, and there is some school that recommend in the same time. He has skeletal class 3 of -4, which is Dr. Adel cutoff point for surgery. And he has very proclined upper incisors. And this is him prepared for surgery in pre-surgical orthodontics. The the negative overjet get more pronounced, and then the surgery is done through a combined surgery, maxillary protraction and mandibular setback. This is his occlusion after the surgery and after post-surgical orthodontics with normalized in all dimensions. And this is his there is a massive change in the facial and dental characteristics of the patient from the time of surgery, from the time before treatment till after orthognathic treatment. Okay, this is the end of my 5th case. I know I have 2 or 3 minutes left. I will jump into my 6th case, which is, what about if we have a periodontally compromised patients with a class 3? How would we manage with them? And I wish if I can have more time to go through it, but I'll just pass quickly, and I'm happy to answer any question. Let's see. This is a 36-year-old lady with compromised dentition, class 3s of -3 millimeter, midline diastema and high labial frenum attachment, spaced and proclined lower incisors, treated with control of periodontal disease, laser frenectomy, Invisalign aligners, and permanent bonded retainer at the end of treatment. It's very clear. Interestingly, here the effect on the facial profile is all dental effect, because skeletally she's class 1. But because of the perio condition, it is going and affecting the profile. This is her with gingival recession, and after perio control, midline diastema, and we did laser laser frenectomy for her, as well as periodontally control the condition. As I said, she's a class 1 skeletally, but dentally she's a class 3. I'll just run into the management. I manage it with Invisalign, aligners. This is the Invisalign clenched start. This is the plan. There is some IPR in order to normalize the class 3, because both upper and lower arch treatment, when we did the space analysis, we said that we need some IPR. This is the end result through the clean check, and I'll show you quickly what is the clean check. This is the end result, the real end result, the clinical end result. This is how we compare. This is the top is the clean check comparing with the real one. And you can see the periodontal outcome is really massive. There is a lot of creeping of the gingival interdental papillae into the spaces. This is her before treatment and after Invisalign treatment. And we can see the profile, how the profile gets better with treatment, as well as concentrate on the periodontal quality after treatment. And that's why we tell our students always, malocclusion could really jeopardize oral and dental health. So we started with this slide saying the worst things you can ask an orthodontist is to treat class 3s. And I think after Dr. Adil's presentation and my presentation, it is the broad spectrum of class 3 cases are treatable and with considerable amount of success and with significant stability. Thank you.
Thank you, Dr. Abbas, for this nice lecture about the class 3 discrepancy in the lower jaw. But if you please, we have some questions about that. First of all, we are so lucky about the treatment of class 3 in the primary case, primary dentition. Did the elastic traction forces doesn't affect the stability of the primary teeth in carrier motion? This is number 1. Okay? Second one, about also the cases which is treated by class 3, is still in need of genioplasty. It doesn't address the chin.
So the first question was, treating primary dentition with carrier motion 3, would it affect the stability of primary teeth? Actually, as I said, the protocol for the elastic has to be lighter and more gradual compared when you deal with young adult or with older children. And from my experience, if you go carefully about it, and you have, before you do selection of the case, you have to look to the roots, because it is not of no use if the canine and E already resorbed. So you have to select the timing of your treatment. And if you select it well and you use considerable amount of care and caution and selecting a lighter protocol of elastic, I think you can achieve a lot of things. The second question, the doctor is asking me, what about the end result of the surgical case, whether it need genioplasty or not? I think the patient was happy with the plan with the surgeon that it goes with, because what is my surgeon doing? He goes through it, show them how they look, they will look after that, and then decide. And if there is a question mark regarding surgery, genioplasty, he will discuss that we might need it in surgery, and then we'll do it.
Depending on patient's demand.
Yeah. In this case, it's not needed.
Is there any question from?
How can you judge lateral cells without under age of 7 years?
The question is, would you...
How could you judge lateral cells under age of 7 years?
The question is, how would you manage with lateral cell? Judge, you mean? In this case, it was mainly dependent on a clinical. We did cephalometric analysis, but we treat her because of the clinical presentations, mainly.
Okay, thank you, Dr. Abbas, very much about this comprehensive